Welcome to WEO's ADEC virtual course. We will now hear a welcome from Professor Tajiri.
Thank you very much attending the ADEC virtual course while all of you are extremely busy. Although this course should have been held at APDW this year, it is in virtual due to the global spread. So we will organize the third WEO Congress end 2022 Kyoto in May 2022. Although there are some concerns regarding the Congress format and the program structure of end 2022, we are, of course, Emra, our friend, we are working hard to solve problems and make the Congress successful. I hope corona pandemic will be converged May 2022. Everyone, please join end 2022 and meet together in Kyoto, Japan. Thank you.
We will now hear a welcome from Dr. WEO, Course Director.
Okay. Welcome to the ADEC, everyone. I'm Noria Uedo from Osaka International Cancer Institute. I introduce ADEC briefly. ADEC stands for Advanced Diagnostic Endoscopy course, and it was started, I heard, that more than 15 years ago by Professor Ray to learn advanced diagnostic endoscopy and to improve knowledge and practice of endoscopy around the world. And it is usually held, as Professor Tajiri mentioned, in conjunction to the International Congress. But because of this COVID situation, this course is held virtually this time. Anyway, I organized the topic today as IEE, Image Enhanced Endoscopy for Upper GI Tract, New Evidences and Technologies. As you know, in the past, we usually use chromoendoscopy for image enhanced endoscopy, but in 2006, NBI was launched in the market and it changed the situation. So it is more than 10 years for us to have equipment-based image enhanced endoscopy in clinical practice. But at the beginning, it is like a kind of a toy of enthusiastic endoscopy, but nowadays it is really a part of our clinical practice. So accordingly, we have a result of large-scale clinical trials. So in this course, I invited doctors who are involved or even conducted the large-scale study regarding to image-enhanced endoscopy. And I also invited Dr. Hong Chip from Hong Kong, who is involved in Asian Novel Bioimaging and Intervention Group, which works for education and training of IEE in Asian country. So they are generously sharing their experience and knowledge with us. I hope everyone is enjoying this course and it will contribute to the improvement of your clinical practice. So I would invite Professor Jean-Francois Ray and Hisao Tajiri to chair this session. Please start. First presentation.
You get it?
Not yet.
Not yet.
Oh. Again.
Okay.
Yet? You see?
Perfect.
Perfect. Okay. So thank you, Professor Uedo. It's really a pleasure this morning to be with you. Just recovery from a bad disease, you know, infectious disease. So the diagnosis of Barrett esophagus and adenocarcinoma with image and endoscopy have been a breakthrough during the last 10 years. And now, if you have some doubt with artificial intelligence, we should manage all these patients differently. So what is the goal for education aim? Barrett and adenocarcinoma. Identification of Barrett esophagus need high definition endoscopy that is available everywhere by the time being. Assessment of Barrett esophagus with image and endoscopy, it's important to detect Barrett esophagus without dysplasia, Barrett esophagus with dysplasia, and Barrett esophagus with adenocarcinoma. If we look about, the identification of Barrett, if we look about, the improvement of endoscopic imaging, by the time being, we are able to design benign without dysplasia. We follow for medical treatment, benign with dysplasia, and we follow with endoscopic treatment, and in some cases, we send for surgery. And of course, when the deep invasion of the easy junction carcinoma is treatment by surgery. Currently, all major endoscopic maker give us exactly the same kind of tool. So we have no question of NBI, LCI, white light, black and white, and so on. Everything is the same. So we have an optical, let's say, that kind of optical NBI available everywhere. And so we all speak the same language. For many years, it was difficult to understand each other because we have different equipment. We have to come back from the Prague classification and published here by Pratik Sharma in 2006. It's important for us to see really the landmark with the easy junction, the lung of intestinal metaplasia, and also the length of the tongue. So that means we have to measure the length of the Barrett. And more the Barrett is longer, more dysplasia, more high-grade dysplasia could occur. And you see here, this picture from Pratik Sharma, a perfect in white light aspect of the Barrett esophagus with various tongue. What we are looking for? We are looking for classification of NBI pattern. NBI pattern is a mucosal pattern and vascular pattern. In both, we are looking for regular, irregular, regular, or irregular. So any endoscopy, we assess very minutely the vascular pattern and the muscular pattern, but both are essential. And this is an aspect, a very nice aspect on NBI of a mucosal pattern. You see the mucosal patterns are very, very regular. This is a squamous cells, but this is the Barrett cell here. And if we use magnification, you see the vascular is very regular. Your vessel are regular shape and so on. So that is really a very important point. Of course, in that case, you see the mucosal pattern is much more irregular here. And if you have a closer view, and in that case, some cells are totally different from the other. So that means it's a irregular muscular pattern. Same for the regular vascular pattern. This is a vessel. We have to look very carefully about the minute vessel here and here. all the network of the vessel are perfectly regular. That is reassuring for Barrett esophagus. This is a very old slide, and you see again the easy junction. We were looking with a very detailed vascular network, regular, and this is a Barrett esophagus without dysplasia. Again, global aspect, muscular pattern regular, vascular pattern regular. We are all the criteria for intestinal metaplasia. That means it's a Barrett, but with regular histopathology. So it's a Barrett with intestinal metaplasia without dysplasia. If we are using, for example, the BLI and NCI, you see exactly the same result from Fuji aspect of vascular pattern here, and vascular pattern here, and inside the mucosal pattern is also regular in a short Barrett esophagus. Of course, more the Barrett is short, more is difficult to assess. And again, the aspect, you see the vessel here, the vascular, here, vascular, mucosal. It's a mucosal pattern, intestinal metaplasia, regular histology. And in that case, you see the big difference. On this part of the slide, you see already there are some disappearance. The vessels are not so regular. And if we use magnification in one part of this slide, you see the disappearance of some vessel and mucosal. But that is irregular vascular pattern in case of dysplasia. An example with Barrett esophagus, white light Barrett esophagus, and you see in that case the vascular pattern was irregular, and it's an old slide from 2005, and you could see here the pathology. That means it was a Barrett esophagus with intestinal metaplasia and low-grade dysplasia. And this is my first paper in DDW 205 with NBI. And you see at that time we are using still, some acetic acid aspect. Now is anymore we don't use, but I draw your attention here. You see here the mucosal pattern totally disappear. The vascular pattern are very irregular here. And this is also another part. You see some redment of the vascular pattern and all the other disappear. So in that case, the pathology was high-grade dysplasia with local neoplasia. So it was exactly what we could expect from the NBI. And again, mucosal pattern irregular, vascular pattern irregular, high-degree dysplasia. And you know what high-degree dysplasia and neoplasia are very close. Same aspect, you have to focus very carefully about, this part of the picture where the vascular pattern are irregular, the muscular pattern also are irregular. So everything is mucosal, vascular, everything is irregular, so it's a high-grade dysplasia. Same with Fuji. This is a very nice picture for Fuji. And you see here the Barrett esophagus, here. But on that part of the picture, they are grossly abnormal. And you have to focus here. If you look with LCIBC here, their mucosal pattern are irregular, so disappear. Vascular pattern also disappear, and it's a T1 lesion. So that means without histology, we could make the diagnosis of carcinoma, early carcinoma. But it's an important paper from Pratik Sharma. And you know, this paper from Pratik Sharma show for the expert, but I hope it's 10 years ago now, everybody should be an expert. You know, the sensitivity, the specificity of NBI for intestinal metaplasia and for NBI for high-grade dysplasia are very high. There are another publication 2 years later with the group of Pratik and AMC group. And again, you know, the agreement for sensitivity, for specificity was quite high at that stage. But that is the current situation with the image enhanced endoscopy. And now we have the artificial intelligence. You know how the study are to be designed with thousands and thousands picture, good picture, and train. And this is why they could, they just publish, you know, a CID system. We could help to make not only biopsy, but could make delineation. So we should have this tool available, and we have already some tool available for the colon in order to make the white light diagnosis, NBI diagnosis, and then we had artificial intelligence. Of course, it's early diagnosis, and there are still some missing. In that case, you know, the computer was not able to identify properly the Barrett esophagus. This is a slide for me is obsolete because it's based on the protocol Seattle. Nobody used protocol Seattle for many years because when we try to use protocol Seattle, we know after 3-4 biopsy, you know, we don't know exactly what we are doing. It's why we know random biopsy for me is totally obsolete. We should make only specific biopsy based on NBI and later on based on the artificial intelligence. It's why, you know, our management should be much more accurate. So we should assess properly Barrett esophagus without dysplasia, Barrett esophagus with dysplasia, and of course, high degree dysplasia. What is really a percentage of population we have to follow very carefully. So, you know, in summary, what are the risk factors for neoplasia? You know, the annual risk factor is 0.6 for non-dysplastic, but you know, for high-grade dysplasia is 1%. The survival rate on 5 years cancer is 15 to 25%. So we have to treat the patient before cancer. They have a guideline for surveillance everywhere now in the world. And what's important, we have endoscopic treatment. Endoscopic high degree dysplasia should be treated very actively. EMR, ESD, prophylactic ablation. So that means the patient sent to surgery should be limited due to the development of the endoscopic technology. And finally, like Professor Isao Tajiri and Professor Emma, see you in Kyoto 2022. Thank you.
Thank you, Professor A, for excellent presentation. And I forgot to say, but for audience, if you have any question, you can use question and answer function of the lower part of the screen, so that even during the presentation, we can pick up your question and then try to answer as much as possible. So actually, we didn't have a question. So maybe we would invite Honchip for his video lecture, followed by case discussion. Honchi, please.
Good afternoon, ladies and gentlemen. First of all, I would like to thank the course director, Dr. Noria Wedo, Professor Ray, and Professor Tajiri in inviting me in this meaningful advanced diagnostic endoscopy course. The topic that I'm going to present today is diagnosis of esophageal SCC in image-enhanced endoscopy, NBI, and endocytoscopy. I'm Dr. Han-Chi Yip from the Chinese University of Hong Kong. These are my agenda. So we'll first talk about principles of NBI. Usually, when we look at a red apple in bare white light, so usual sunlight, consisting of all three colors, the blue and green light would be absorbed. On the other hand, the red light would be reflected, and therefore our eyes would perceive this as a red apple because the reflected red light goes into our retina. On the other hand, if we shine only blue and green light to a red apple, because all the green and blue light will be absorbed, while there's no reflection of red light. So our eyes would indeed interpret this as a black apple. Similarly, if we shine blue light onto surface epithelium, because of the poor penetrance, most of it would be reflected, some would be absorbed in the capillary level, and then would show up in high contrast in the subepithelial capillaries. But all of the others would scatter at the superficial layers, and so the venues and the veins located deeper would not be shown. If we shine green light, again, it's only weakly absorbed, partly penetrated in the surface epithelium, so that the capillary level could be seen, and then it's scattered in the deeper layer. For venues located, there would be some absorption, but partly penetrated, and they will not penetrate into the deeper vein. And as a result, again, you can see subepithelial capillary and venues in the middle part, which would be shown in relatively low and high contrast, respectively. If you shine red light, on the other hand, because of the high penetrance of red light, basically it penetrates through the capillaries and the venues and without much absorption. And there is also minimal absorption in the venous level in the deeper part. And as a result, you can see vein in the deep part in low contrast. So this is a summary. When you shine blue light, you show the capillaries. When you shine green light, you show slightly deeper venues, and red light, you show submucosal veins. And on the other hand, if you shine a wide width light, the contrast is not very well seen. But if you shine a very narrow bandwidth of light, there will be a very sharp contrast of the mucosa, which you can see. So these form the basis of the narrowband imaging, where a filter has been applied in front, filtering the red light and only showing a two specific narrow wavelength of light and enhancing the surface pattern and the surface vascular pattern. Indeed, similar physical properties have been utilized for the latest NBI technology, where there's no longer a filter, but rather LED lights with blue and green specific length, which has been emitted by the LED. And with the Fujifilm BLI, it's also similar because blue and green laser light is shined and giving rise to similar appearance of the mucosa. Now back to the esophageal cancer. For squamous cell carcinoma, detection with ordinary white light endoscopy is indeed very difficult. You can only rely on subtle change in the color. It may appear slightly red in color, or there would be some surface changes, nodular appearance. And also you can see disruption of normal esophageal vasculature along. But with narrowband imaging, indeed, it's much easier to be seen. So it would appear as a well-defined brownish color chain with a demarcation line. And within this lesion, you would see abnormal intrapapillary capillary loops called IPCL. So the reason for brownish color change has been investigated in a study, and it has been found that the main reason is because of the thinning of the epithelium and thinning of the keratinous layer of the cancerous mucosa. And as a result, the blue and green light being shine onto the cancerous mucosa has a different reflection as compared to a thicker normal mucosa, thereby appearing brownish in color. Now back to the IPCL. IPCL is capillary loops located in the most superficial part of the surface epithelium, and it connects to the branching vessels in the deeper side. In more sophisticated imaging, you can see that the IPCL being located most superficially in the squamous epithelium, followed by some capillary network deeper, and then drainage vein, collecting venues, and also drainage vein in the submucosas. On narrowband imaging, these IPCL appears as very small dark dots, which are loop in appearance, and they appear scattered in a normal situation. And you can also see those branch vessels. These are green and located deeper and much larger in size as compared to the IPCL. With increasing neoplastic change, there was increasing pathological change with these IPCL, and the 4 cardinal signs include dilatation, tortuosity, variable caliber change, and non-uniformity of IPCL morphology, as you can see on the left side pictures. So the performance of magnified MBI versus white light endoscopy has been investigated in a randomized trial of 320 patients. And what was found was that in patients at high risk of esophageal cancers, both sensitivity and overall accuracy is better, much better with narrowband imaging as compared to white light endoscopy in both a detection of esophageal cancers as well as head and neck cancers. Of course, chromoendoscopy has also been utilized for decades, and that includes Lugol's iodine chromoendoscopy, where we usually spray a concentration of 0.5 to 1% Lugol's iodine onto the surface mucosa. Higher concentration generally are not recommended because of the potential irritation to the esophageal mucosas. And what we look for is unstained area, which is shown on the left side picture. The problem with unstained area is that there is a high sensitivity but a variable specificity. So alternatively, we can also look for a pink color sign, which has to wait for about 2 to 3 minutes before it's been seen after spraying Lugol's. And it has a much higher specificity, especially for high-grade lesions or early cancers of the esophagus. The performance of narrowband imaging with Lugol's chromoendoscopy has been investigated in this study with propensity score analysis, and after matching of 80 total cases where both modality has been utilized, chromo with unstained area and non-magnified MBI with brownish color discoloration positive, it was found that the sensitivity were more or less the same, but the specificity seems to be higher with MBI, and thereby the overall accuracy was also higher with MBI. A meta-analysis published in 2015 showed that narrowband imaging and Lugol's chromoendoscopy were much better than white light endoscopy, with narrowband imaging AUC of 0.97 and Lugol's chromoendoscopy AUC of 0.82. And I must emphasize that because of the similar pathophysiology, screening of the head and neck area, as well as the esophagus with narrowband imaging is equally important with patients at high risk of cancers. So for those with heavy drinker, heavy smokers, be sure you should screen the hypopharynx as well. And in this particular patient, you can see in the arytenoid fold, there is a lesion located, which is very small and early in size and easily resected. Studies have, meta-analysis has found that the prevalence of second primary lesion varies. Some studies even show a more than 20 to 30% risk of a synchronous lesion, second primary in the head and neck in patients who have a known esophageal cancers. And interestingly, if there is a esophageal cancer, if you located a second primary, most of these second primary are at a low stage, which means if they are detected, they are potentially curable by local regional treatment as well. So next is about characterization of esophageal lesions. with the aim of differentiating malignant from benign lesions, predicting depth of invasion, and lastly, delineate the lateral margins of lesions. So to characterize esophageal suspicious cancers, we can rely on morphological appearance with Paris classification, MBI magnification appearance, and Lugol's chromoendoscopic appearance. The conventional white light imaging, we can classify lesions according to the Paris classification into type 01, 2A, 2B, 2C, and type 3. Traditionally, it's thought that for lesions that are sessile or excavated, generally they had a very high risk of SM2 or deep invasive cancers. But recently, there are some data showing that this macroscopic classification might not be as accurate, as some of the sessile lesions did appear to be M1 or M2 early lesions as compared to deep excavating, deep invasive cancers. For magnifying endoscopy appearance, we again look for brownish color change, and also we studied on the morphology of the IPCL based on the JES recently published classification, which is a combination of the old Inoue classification and the ARIMA classification. So as we all know, with increasing depth of invasion of cancers, there is increasing disruption and neovascularization of the tumor vessels. So because of that, there is an increasing change in the morphology of the IPCL. This is the JES classification, which divides into vessels of A1, A2. Generally, these had no brownish discoloration, and the vessels are non-dilated, homogeneous, uniform in appearance, and they have a very normal appearing IPCL. For B1 vessels, there is brownish discoloration, but the vessel still forms a loop, although they are already showing abnormal dilatation and non-uniformity. And also there could be potential small avascular area less than 0.5 millimeters corresponding to M1, M2 cancers. B2 vessels are non-loop forming and dilated, and also with a vascular area that is medium in size, 0.5 to 3 millimeters in size, and corresponding to M3 to SM1 cancers. If you have non-loop vessels that are 3 times thicker than a B2 vessels, they are generally appearing in green, and these non-loop thick vessels, and also with a very large avascular areas, are corresponding to deep SM invasive cancers. Another examples of pictures showing how loop vessels in B1 can be seen, and non-loop vessels in B2, which you can see scattered around this region, and corresponding to M3, SM1 cancers, and very thick green vessels corresponding to SM2 invasive cancers. For avascular area, similarly looking for 0.5 millimeters small AVA or 0.6 to 3 millimeters or more than 3 millimeters. So if you're using a magnified endoscope, generally the hole in deepest magnification, highest magnification, the width of the screen is about 4 millimeters and the side is about 0.5 millimeters. So that can be used as a guide to help you to gauge the size of the avascular area. So the accuracy of JES classification generally is very good. You can see the accuracy of more than 90% in all 3 types of vessels. But one thing to mind is that for B2 vessels, if you see them, the positive predictive value is slightly lower at 75%. And therefore, you might consider addition of B2 vessels, especially when you have discordance macroscopic findings that you're not sure whether this is a deep invasive cancer. So what we can do with EUS is a probe-based EUS. So previous studies have found basically magnifying MBI with probe-based EUS generally has a very similar sensitivity and specificity and accuracy as compared to magnified MBI. So Lugol's chromoendoscopy, in my personal opinion, is that it's best used to delineate the lateral margin especially during endoscopic resection, because it helps you to get the lateral margin without needing magnification. So, but side effects, of course, there might be retrosternal pain, mucositis, aspiration pneumonitis, and sometimes it induces quite a number of contractions, and the ESD can be difficult. The solution is to use sodium thiosulfate to wash off the glucose stain and help with the contractions. So you may ask if we can see deeper into deeper cellular levels. So there are two main streams of cellular level imaging at the moment. One is endomicroscopy, such as the laser scanning confocal microscopy, utilizing fluorescence-based contrast. And the one we're talking about today is endocytoscopy, where we are using cellular dye staining and ultra-high magnification endoscope. So it's not a new thing, because prototypes of endocytoscopy was developed since 2003 by Olympus Medical Systems. You can see that initially it's a probe-based endocytoscopes, where you can apply it through the channel of original endoscopes, and it has a fixed magnifying methods. And since 2009, there's a change in the modality, where the endocytoscope is incorporated into the scope, and there's a lever that you can now gradually increase the magnification, and also a decreasing size of the endoscope itself, and the magnification power is up to 500 times. So this is the commercially available type now, which is 9.7 in millimeters of size with a 2.2 millimeter working channel and a magnification ratio of 520x. Using this monitor. So you don't need to use a cap for this, because you're touching onto the mucosa, and the light would transmit and scattered and then go back to the objective lens, providing the images. And you can see on the right side how in depth, how high magnification this can give on a gauze. Of course, you need dye to stain onto endocytoscope. So the common dye that we use include methylene blue, which stains on nucleus and cytoplasm, crystal violet, also with cytoplasm staining, toluidine blue, also with nucleus and cytoplasm staining. So as reported by Dr. Minami from Japan, the CM double stain is probably the currently most commonly used modality for esophageal and gastric assessment. The method that we commonly utilized would be a combination of crystal violet with methylene blue into a 10 mils mixture. And we only aspirate 1 mil into the syringe, and then aspirate another 9 mils of air so that we can spray onto the target lesion. This helps us to stain only the target lesion to avoid obscuring the true lesion and failure to find the lesion. Of course, you can still use spray catheter, but after spraying catheter, sometimes it's not easy to find back the lesion for a careful assessment. So for esophagus, what we can see normally is the squamous cells being stained. So you would focus on looking into the nucleus shape, the density of the nucleus, as well as the nucleus cytoplasm, the NC ratio for these images. So looking in a more magnified view, you can see this is the cytoplasm and these are the nucleus. So it's almost like going back to our pathology class. So in neoplasia of esophagus, there is an increasing abnormality of the NC ratio, so increasing nucleus to cytoplasm ratio, and also you can see the increasing in the irregularity of the cell distribution and also the cell arrangements. And sometimes you can even see mitosis, but it's not very easy to see, but you can see large nucleus. So in this study published 2002, you can find that the ECA 4 and 5 corresponding to a very abnormal and increased cellularity and NC ratio has a very good concordance with Vienna type 4, type 5 lesions, with the overall accuracy, sensitivity, and specificity all higher than 91%. Taking this as example, this is an esophageal lesions. You can see abnormal B1 vessels on this ultra-high magnification on MBI. And on endocytoscope, you can see obvious ECA5 appearance with a very dense nucleus abnormally appearing shape, not roundish nucleus, and the cytoplasm is NC ratio is much increased as compared to the side where you can see a demarcation where inside this area there is not much nucleus, and the cytoplasm and the nucleus ratio is much better than the ECA5 area. So in conclusion, ladies and gentlemen, the use of IEE such as NBI, BLI significantly improves detection and characterizations of early esophageal squamous cell carcinomas. It's important that we assess the lesion carefully, that we can predict depth of invasion, which would guide appropriate treatment like ESD, chemoradiation, or surgery. And finally, endocytoscope is a novel technology that enables in vivo real-time cellular images, but its specific roles remain to be defined in clinical application. So thank you very much for your kind attention, and questions are welcomed. Thank you.
Thank you, Fonchi. Very excellent and comprehensive video presentation as always. And one quick question: you said that what do you think about endocytoscopy practicability? You know, as you mentioned that it still remain the space to application in a real clinical practice, according to your experience.
I must say, at this moment, it's not easy to find a specific role for the endoscytoscope. Mainly because, as we already seen, the current modality of image-enhanced endoscopy, be it NBI, be it BLI, or even Lugos chromoendoscopy, has a very good accuracy. So whether we can really use the endocytoscope as a modality to predict, it's not useful to predict cancer or non-cancer because we already have good modality. And in my personal experience, I don't think there's still no good classification system to say whether we can divide them into the depth of invasion based on the endocytoscopic appearance yet.
Okay.
So I think we still need some research onto this area. And also the application, the usage of the endoscytoscope is not easy. So I'm sure you have experience as well.
Yeah.
So you need to be very focused at one specific spot, and your scope cannot move at all. And at the same time, you don't have a cap. So in order to achieve a good image with the endocytoscope with staining, you need contact onto the mucosa. So that means if the mucosa bleeds, then there's a problem. And also, if you move too quickly, you basically move far away from the lesion, then again, you cannot see the lesion. So there is a bit of learning curve as well in terms of using it. So for gastric lesion, it's even more difficult because of all the mucus in the stomach as well.
I see. So I will looking forward to wait your publication in the future. Okay, and before moving to Honchi's case discussion, I want to pick up two questions about the Barrett's. So one question is for how do we survey 1 centimeter, less than 1 centimeter Barrett's with intestinal metaplasia? Should we survey or not necessary? Professor Ray, can you answer for this question? 1 centimeter short segment columnar epithelium with intestinal metaplasia.
Look about the questions. It's about the length of Barrett.
Yeah, 1 centimeter short columnar epithelium with intestinal metaplasia. Does it need surveillance or not?
Short Barrett is less than 3 centimeters. Long Barrett is more than 3 centimeters. And ultra short Barrett is less than 1 centimeter. That means for 5 millimeter to 10 millimeter is ultra short Barrett esophagus. And it's why it's sometimes very difficult to assess, because with the breathing movement, we have difficulty to assess the length. But also in some cases, not only regular Barrett around the esophagus, it's just a tongue. And but even ultra short Barrett esophagus, you could have high grade dysplasia.
Okay, so, and also I think risk is really depend on the length of Barrett. So probably very ultra short, very low risk,
Yeah.
maybe. And also another question, one question is which is better, NBI or acetic acid? Or which should we use for real clinical practice for surveillance?
I use acetic acid with my friend Lambert for 20 years, but I think, you know, now we have NBI, and an early NBI, I'm using acetic acid and NBI. Now we have a high level NBI capacity or diagnosis. I don't use anymore acetic acid. I assess
Easy to use. Yeah, easy
much
to use.
easy to use, much
I
easy to
see.
use, and much reliable to use.
And maybe diagnostic accuracy almost similar
Yeah,
between
yeah.
acetic acid
Oh
and
yeah.
yeah.
When you know how to use
yeah.
acetic acid, was a very good tool.
Mm,
But
mm,
by the time being, it's so easy with NBI, and
see.
the less cumbersome, no side effect. So, and
So
I
both
drop,
better than white light.
I
Yeah,
drop
both
acetic.
better than yes.
Yeah,
Okay, both better than white light, but NBI is easier
yeah.
than acetic acid. Okay, so we answered the question. So, Honchi, please share your
Okay.
case. Yeah. Maybe we can discuss with other panelists, including Dr. Yoshida Sensei and Doi Sensei as well later. Yeah.
So I'm going to present a case. So it's actually because I'm a surgeon, so we're actually seeing this case referred to as a surgical case. So it's a 61 years old gentleman without any significant past health. He presented with a right side cervical lymph node that's quite large in size. At that time, still mobile without any skin involvement. And he was referred first to an ENT surgeon, which confirmed that the lesion was metastatic squamous cell carcinomas. And the initial laryngoscopy failed to identify any lesion. But nonetheless, he was referred for a whole body PET CT. The PET CT confirmed that there was a lymph node in the right side, level 2, a size of up to 4.5 centimeters with a high SUV uptick. There was no definite significant lesion seen apart from a slightly mucosal thickening in the lower esophageal mucosa. There's also no other lymph node involvement. So this was the OGD, part of the video of the OGD that we referred to us to do. So I'll just let you quickly skim through the video and then we'll discuss it. Perhaps I would skip a bit. So this was the white light.
So this is proximal to arytenoid. So
Yes, yes.
mesopharynx, maybe.
Yes, yes.
Yeah.
So and it's on the right side, so it actually corresponded to the area where there was a lymph nodes. Then went down.
Are you using a cap?
Yes, a soft black hood was applied to the top.
It helps to visualize upper
Yes.
sphincter. Yeah.
Yes, yes. So I think for cases like this, it's very crucial that we have to be slow when we enter the cervical esophagus to make sure we do not miss lesions in the cervical esophagus as well. So this was the second lesion. So just a very quick quiz. So which location has the highest incidence of synchronous lesion if you have a squamous cell carcinoma of esophagus? I think we have a poll.
Yeah. Oh, panelists cannot vote.
Because you know
What?
the answer, so
No. We can discuss.
So shall we close? How many have
Yes.
voted? Yeah, let's see the answer. Okay, so I guess most got the answer right. So indeed, hypopharynx has the highest risk of a synchronous lesion. Actually, conversely, if you have a patient who presented with a hypopharyngeal cancer, it's equally important to screen the esophagus as well. I think most countries would have a screening protocol in place. For those head and neck cancers, we have to screen the esophagus. I think oropharynx is also a high-risk region. So we in our hospital, we basically screen all patients with an oropharyngeal cancer, hypopharyngeal cancer, sometimes even oral cavity cancer. We would screen them with narrowband imaging, the entire esophagus. Yeah. Okay.
According to our data, about 10% of incidence of coincidental cancer
Yeah, I
in
think
head and neck. Yeah.
Yeah, I think our data was 18%, so even high. So some
I
variation.
see.
Okay, so this was the cervical esophageal lesion. So we saw it in the end of the video. So I took more pictures of the lesion. So let's discuss this. So what is the predicted depth of invasion of this lesion based on the GES classification? So shall we proceed to the poll?
Maybe we can ask a comment for Dr. Yoshida Sensei or Doi Sensei.
Oh, yes, of course.
But not yet. Still they are voting. So after the answer, no, it's okay.
Okay, so we have
Okay.
almost
Yoshida Sensei.
equal.
Yeah.
Yes.
LPM and shallow semicosa.
I think T1 AEP LPM because I think IPCL type is type 1 in Japanese classification. It's closed loop, I think.
How about Doi Sensei?
Yes, I also think this region is clinical T1A EPLPM because IPCL is JSW1. The vessels is tortuosity, caliber change, and dilated shapes. But IPCL shape is keep in loop. So I think this region is type B1 and EPLPM. And no avascular area.
Okay. Could you explain, Honchi, about the finding of IPCL and why we can call this B1?
So maybe I go back to the previous slide. Okay, so you can see on this photo, first of all, there is a clear brownish demarcation within the area where you can see dilated abnormal vessels. So just from a macroscopic appearance, this is a very suspicious lesion of neoplastic lesion, squamous neoplastic lesion. So this warrants further assessment using maybe a higher magnification. You can use magnified scope. You can use maybe a near focus scope. Could probably give you a good enough images. The recent developed extended depth of field scope, the EDOF scope, may even give you better view, because if you use that type of scope, then you would have a focused view in the entire screen. But anyway, then we try to look into each of these IPCLs, and we focus mostly on the dominant type of vessels. So because of the presence of brownish discoloration, and also you can see each of these individual IPCLs are almost different in appearance and different in morphology. So I would say this is definitely not part of the A vessel, so it must be B. So the question is whether this is B1 or B2. We don't see any very large greenish vessels, so it's not B3, definitely. So the next question is whether we still, the vessels itself still remain loop-like. So if you look carefully in each of these small, each of these dots, so basically they are still forming loops. Each of them curl back to each other as a loop appearance. There is no definite region where you can see a non-loop vessels. So based on this classification, it belongs to a JESB1 vessels. So according to classification, the predicted depth is T1A, EP, or LPM. Maybe in Western society or Western pathologists, most likely they will give you the information as a high-grade dysplasia, I would say. Yes.
Okay, thank you.
So,
And then, do you have any still
yes.
quiz? Yeah.
No, next. So we have the third lesion. This is in the
Oh.
distal part of the esophagus. So, so we'll spend a bit of time looking at this photos. So, and then what would you classify based on the JES morphology?
Could you back again?
Yep.
Okay. Okay.
Okay, so maybe we can just show the poll question, then I'll just keep it in here.
Image is a bit small.
Yes, unfortunately. This is a case a bit long ago. So anyway,
Okay, okay.
And there was easy bleeding, so I couldn't put very close.
Okay, P3, P2. Okay. Could you explain, Monchi?
I would say this is B2 because I didn't see hugely enlarged vessel. So the definition of B3 is that it's 3 times larger than a B2 vessel. So it would appear usually thick and greenish in appearance. So in this 2 pictures on the left, I don't think I saw any grossly enlarged vessels. Noria, do you have?
Very brownish color in the middle image is just a bleeding, maybe.
Yes.
I see. On the surface,
Yes.
not a vessel. I
Yes.
see. So maybe but maybe too small to evaluate.
Yeah, maybe it's a bit too small.
But I assume it's B2.
Yes.
Okay.
So, but as I mentioned, the B2 vessel, the possible predictive value is a bit variable. So we did a EUS. So actually, if you see on the EUS, there is a area where there's high suspicion of deep SM invasion over this region. The SM layer is being involved, and it almost encroaches onto the muscularis layer. So sonographically, this is more compatible with a deep invasive cancer. Okay, so this is a difficult question. So what would you do? So now we have a patient with 3 lesions and also a lymph node in the neck. Okay.
Okay.
Shall we end the poll?
So 0% for referred to surgery, and 41% for referred for oncologist for primary chemoradiation, and 0% palliative treatment. So everyone think it's still treatable, and 59%. This is the most combination approach to different tumor.
Okay.
Okay.
Well, I think. Well, what would you suggest, Nori? I think there's no right answer in this case, so it's just for
Yeah.
discussion.
So maybe for us, maybe we cut, as you mentioned, that B2 and also even EUS sometimes overdiagnose the depth. So maybe we cut the most deep lesion and then, yeah, evaluate the histological tumor stage. And then maybe we would decide.
I see, I see.
Mm.
So in our situation, we are, I think upon multidisciplinary discussion, so we thought that number one is the esophageal lesion looks slightly deeper invasive. It's the appearance is most deepest lesion. And there's also a large neck lymph node. So we are worried that there is any lymph node involvement regarding the deepest invasive cancer. So we thought that just a purely endoscopic approach for the deepest esophageal lesion may not be appropriate. So of course, it really upon for discussion. So there's no real right or wrong answer. One option is we can do a total pharyngeal laryngoesophagectomy, which would potentially resect every lesion, but it will result in the worst functional outcome for the patient. There is a loss of the voice, and there's a total esophagectomy. So primary chemoradiation is difficult because we have the neck lymph node, we have pharyngeal cancer, we have the esophageal cancer. In our experience, in our center, our oncologist is reluctant to irradiate a long segment of esophagus due to the dose of the radiation that would affect the lungs too much. I'm not sure what your experience is in Japan, but
yeah, we are also the same.
yes, yeah. So it may not be feasible in such a case. So that's why we chose to adopt for a combined approach for the tumors. So I'll just briefly show the plan that we did finally. So we resected endoscopically the cervical lesion as well as the actually the oropharyngeal hypopharyngeal lesions. And then we did a minimally invasive esophagectomy for the deep invasive cancer and then an adjuvant radiation to the cervical lymph nodes, hoping to achieve functional preservation while achieving a cure of all the 3 potential cancers. So maybe I would just quickly show, this was one of the procedure for the cervical, for the hypopharyngeal cancer. So it's a combined resection using an endoscopic approach plus a ENT ELPS approach. So similar to ESD, you just open marking and do injection, but we have a knife that is a needle in shape and which could be inserted transorally to get into the hypopharynx and do the first proximal resection. But somehow the curvature of the knife did not allow us to get deep into the piriform fossa. So it was converted to a more ESD-like procedure where we get the deeper margin out and using forceps to grasp the lesion, and we resected the entire lesion out. So this is not a therapeutic course, so I'll skip. And of course, we proceed to cervical esophageal ESD. So the cervical lesion was resected. And these were the pathology. So the hypopharyngeal cancer came back to be T1B, quite deep invasive, poorly differentiated squamous cell carcinomas. We did achieve a en-bloc complete resection and with negative vertical and horizontal margins. Cervical lesion was only high-grade dysplasia and clear margin. And the esophageal lesion was deep T1B, moderately differentiated cancer of esophagus, but there was no lymph nodes. But the neck had 3 lymph nodes being involved on the right side. Some of them were large and 5 centimeter in size without any extra capsular spread. So I think this was the case that I want to share.
I see.
So yeah.
So I meant that the ESD for esophageal region is it could be come back with only MM or something, so that
Yes.
we can avoid surgical procedure,
Yes.
and also
Yes.
we can reduce the radiation field to
True.
probably pharyngeal cancer is a definite indication for chemoradiotherapy. So
Yes.
that is what I meant.
And
And one question from the audience that the indication of EUS. So is it better to do EUS for all 3 region, or just for difficult region? Maybe pharyngeal cancer, maybe it's very difficult to do
Yes.
EUS because
Yes.
we cannot. Maybe with balloon.
Maybe if you use a radio endoscope, maybe. But if you're trying to delineate T1A from T1B, the radio echo endoscope may not have enough resolution for you to see well. So generally, if you're using a EUS to assess the depth of invasion, we utilize a probe. And you need to be a higher hertz volts of probe, because the lower hertz probe gets deeper, but the resolution is lower. So if you want a high resolution images of EUS, you need about 20 megahertz probe to get the best images. And mind you that air or gas is the enemy of EUS. So you will need to fill the lumen with some form of medium. So one way to use is to use some form of gel, or jelly. So jelly, you can use a dual channel endoscope, put in some jelly through one channel into the lumen, and then use a probe to assess when the jelly fills the entire esophagus. If the esophagus is completely collapsed, again, it's very difficult to assess with EUS. So that's a difficulty. And even in cervical, it's also difficult to use EUS. And not to mention
how about in terms of easiness, or like confidence of prediction of the depth by white light? It means the cervical region looks like a really intramucosal B1 vessel. So do you perform also EUS for both region, or only some suspicious region for deep invasion?
Maybe only selectively. I don't do EUS routine. Well, I'm not expert in EUS, I must say. So,
but actually, it looks really, definitely intramucosal.
Yes.
Maybe EUS does not so much mean additional information.
Yes, I agree. Yeah.
And also recently, there is one prospective study to make diagnosis of depth of invasion of SCC by EUS, and the JCOG study showed that sometimes EUS over-diagnose, so the proportion of over-surgery increase. So it's a very hot discussion for the interpretation. Should we still perform EUS or not? It just adds some invasiveness for the decision.
The EUS maybe is even more operator dependent, because the exact location, and you need to stabilize the scope, and also the image that you have is quite subjective. Sometimes it's difficult.
Maybe it's a Jacob study, so they invite very expert endoscopographer, but maybe we will wait for the actual interpretation in the future. Yeah. Okay. Yeah. Thank you, Honchi.
Oh, thank you.
So next, we will move to Dr. Yoshida's video presentation, and followed by Dr. Dohit's video presentation, both for IEE for gastric region. So please start.
Hello everyone. I'm Naohiro Yoshida from Ishikawa Prefectural Central Hospital, Japan, and I'm glad to have a chance to speak here today. Today, I'd like to talk about the diagnosis of early gastric cancer by image-enhanced endoscopies, including NBI and TXI. Today's agenda is here 3. At first, let me explain about early gastric cancer. Gastric cancer remains important cancer worldwide and is responsible for 1 million new cases in 2018 and an estimated 783 deaths, making it the 5th most frequently diagnosed cancer and the 3rd leading cause of cancer death. In Japan, where the prevalence of gastric cancer is high, the progression of gastric cancer is classified into 2 categories. One is early gastric cancer, and another is advanced gastric cancer. In the Japanese classification of gastric carcinoma, early gastric cancer is defined as gastric cancer confined to the mucosa or submucosa, irrespective of lymph node metastasis. The prognosis of early gastric cancer is excellent. This slide shows the prognosis of surgical operation cases. The 5-year disease-specific survival rate of early gastric cancer is reported as 97 to 99%. In Japan, endoscopic mucosal resection (EMR) and endoscopic submucosal dissection (ESD) have been widely accepted and used for treatment of early gastric cancers with negligible risk of lymph node metastasis. In the patients whose gastric cancer was determined as curative resection or expanded indication, the 5 years of disease-specific survival rates were over 99%. Then we can say that early gastric cancer treatment has great benefit for patients. However, according to the basic principle, to treat early gastric cancer, first of all, we have to detect early gastric cancer. Earlier detection is most important. In high prevalence areas of gastric cancer, such as Japan or South Korea, endoscopy and radiography have been used for nationwide prevention and screening programs of gastric cancer, which is better for detecting gastric cancer. One article showed that sensitivity of endoscopy is little higher than radiography. This is a meta-analysis to evaluate the relationship between endoscopic screening for gastric cancer and mortality. This study indicates that endoscopic screening was associated with 40% relative risk reduction in gastric cancer mortality. From this result, it seems to be certain that endoscopic screening is useful for the improvement of gastric cancer prognosis. However, this study included much advanced gastric cancer. So, how is the effect of endoscopy for detecting early gastric cancer? This study was designed to determine the differences in stage at diagnosis of gastric cancer according to the screening history and screening method. And this shows that screening by endoscopy was more strongly associated with the diagnosis of earlier stage gastric cancer compared with screening by radiography. Then we can recommend endoscopy for detecting early gastric cancer. Next, I'd like to show our study that evaluated detectability for early gastric cancer by narrowband imaging. Conventionally, early gastric cancer is detected by using white light imaging. Early gastric cancer detection is composed of two steps. The first is the detection of the region suspicious for early gastric cancer. We should be aware of the key signs, such as surface and color change, change in light reflection, and spontaneous bleeding. The second is the characterization. After detecting the suspicious region, we need to differentiate between cancerous and non-cancerous regions. Well-demarcated border and irregularity in color or surface pattern are key criteria. If findings of white light imaging fulfill both criteria, we make the endoscopic diagnosis of early gastric cancer. This is the endoscopic imaging classification proposed by Dr. Tajiri. In recent years, image-enhanced endoscopy has been attracting attention for the detection of early gastric cancer. Among these image-enhanced endoscopies, we focused on NBI. This is a schema of the first generation NBI system. The NBI system is an innovative optical image-enhanced technology that involves a narrow bandwidth NBI filter in the video endoscopy system. The central wavelengths of the NBI filters are 450 nanometers and 540 nanometers. Because these narrowband lights are well absorbed by hemoglobin, the microvascular architecture of the mucosal surface can be easily visualized. These pictures are images of the same part of a gastric cancer by magnifying endoscopy. As you see, the image of NBI has higher contrast than white light imaging. By NBI, both the microvascular architecture and the microsurface structure can be clearly visualized. Magnifying endoscopy with first-generation NBI was demonstrated to be useful for distinguishing between cancerous lesions and non-cancerous lesions. However, there was no report about the detection of early gastric cancer. We use non-magnifying endoscopy for detecting gastric cancer. As you see, images of non-magnifying endoscopy with first-generation NBI are too dark in the stomach areas to detect early gastric cancer, which is usually flat and small. In 2012, a second-generation NBI system came onto the market. The second-generation NBI has a new rotary disk filter, which can increase the exposure and improve brightness. Similar to white light imaging, the second-generation NBI enabled screening of the whole stomach. Here I will show you how early gastric cancer was seen in both white light imaging and in second-generation NBI. In this case, the region was a bit obscure in white light imaging. However, as you look at the right image, it was clearer in NBI imaging. Accordingly, we hypothesized that non-magnifying second-generation NBI could detect more early gastric cancers compared to white light imaging. So we conducted an open-label, multi-institutional, randomized controlled trial involving 13 Japanese hospitals. The patients included were those who had concomitant esophageal or gastric neoplasms, or patients with past history of esophageal or gastric neoplasms. Exclusion criteria was past history of gastrectomy. Target region was defined as a region suspicious for early gastric cancer. Diagnostic criteria for target regions were an area with irregular margin, an area with irregular discoloration, one area with irregular surface. This is the flow diagram of this study. After stratification by age, indication, and institution, enrolled patients were randomly assigned to white light imaging group and second-generation NBI group. In the white light group, the gastric mucosa was examined using white light imaging. When we found any suspicious regions for early gastric cancer, we recorded the regions as target regions. After observation with white light, the gastric mucosa was again examined using second-generation NBI. Where other target lesions were detected, they were recorded in a case report form. In the second generation NBI group, the gastric mucosa was first examined with NBI and then examined with white light imaging. After using both imaging methods, biopsy specimens were taken from all target lesions to serve as reference standards for diagnosis. The primary analysis was carried out for only lesions detected as a primary examination in each group. The primary endpoint of this study was the difference in the percentage of patients with newly detected early gastric cancer at the primary examination. The secondary endpoints included the positive predictive value for the diagnosis of early gastric cancer, the observation time, and the characteristics of missed early gastric cancer. Between September 2014 and September 2017, 4,575 patients were enrolled. After exclusion, 2,258 patients were assigned to the white light imaging group, and 2,265 patients were assigned to the NBI group. A total of 2,234 patients and 2,238 patients underwent examination, respectively. Here you can see the baseline characteristics of each group. Age, gender, and indications were similar between the two groups. The most common indication for endoscopic examination was surveillance for gastric neoplasm after ESD. This is the primary endpoint. Detection rate of early gastric cancer in the white light imaging group was 1.9%, while it was 2.3% in the NBI group. There was no statistically significant difference between the two groups. These are secondary endpoints. White light imaging detected 371 target lesions, and the number of early gastric cancer was 50. Hence, the positive predictive value was 13.5%. On the other hand, the NBI detected 282 target lesions, and the number of early gastric cancer lesions was 59. Hence, the positive predictive value was 20.9% in the NBI group. It was significantly better than that of white light imaging. The characteristics of detected early gastric cancer regarding tumor location, macroscopic type, histological classification, size, and depth were similar, with no significant difference between the two groups. In another secondary analysis, the mean observation time of NBI was significantly longer compared to the white light imaging group. In the protocol examination, white light imaging failed to detect 19 early gastric cancers, and second-generation NBI failed to detect 17 early gastric cancers. Then the sensitivity for detecting early gastric cancer was 72.5% and 77.6%, respectively. The characteristics of missed early gastric cancer regarding tumor location, macroscopic type, histological classification, size, and depth were similar, with no significant differences between the two groups. If I can briefly summarize, the proportion of patients with newly detected early gastric cancer between white light imaging and second-generation NBI was not significantly different. This result suggested that second-generation NBI was equivalent to white light imaging in early gastric cancer detection. The positive predictive value for diagnosing early gastric cancer was significantly greater for second-generation NBI than white light imaging. And the positive predictive value is a critical indicator of screening efficiency, and a sufficiently high positive predictive value can reduce unnecessary biopsies and the associated risks of bleeding. the mean observation time of the second generation NBI was significantly longer than that of white light imaging. Despite statistical significance, the difference was only 20 seconds, which may be considered clinically acceptable. In conclusion, the comparable detection rate of early gastric cancer suggests that second-generation NBI is equivalent to white light imaging in early gastric cancer detection. The superior positive predictive value of second-generation NBI suggests that it could be an effective screening modality that may reduce the number of biopsies. At the same time, this study uncovers the current problem to be solved. In this large-scale study, the sensitivity for detecting early gastric cancer of both white light imaging and second-generation NBI was not sufficient. That is, perfect detection of early gastric cancer remains difficult in current clinical practice. At last, I'd like to introduce new technology, which is expected to be useful for detecting early gastric cancer. It is expected to enable the perfect detection of early gastric cancer. This is EVIS X1 series, which was launched this year. It is an innovative system that aims to improve observing performance through new technologies such as TXI, RDI, and EDOF. Today, I'd like to introduce TXI, which is expected to improve the detectability of lesions. TXI is an imaging technology that optimizes the three elements of structure enhancement, color tone, and bright correction based on the information of normal light. TXI lightens the dark area without causing halation and makes it easier to visualize slight changes in color and structure of images. This is the principal drawing of the technology. An input image is divided into a texture component and a base component. After it is properly processed, the two segmented images are synthesized. Then the color processing is performed, and the processing is completed. This function is expected to effectively depict changes in mucosal color, slight depressions, and elevations. Here, I will show you how early gastric cancer was seen in both white light imaging and TXI. In this case, the lesion was a bit obscure in white light imaging. However, as you look at the right image, the red color and slight depression of the lesion becomes more noticeable, making it easier to recognize the lesion. This is the lesion of the lesser curvature of the body of the stomach. Of course, the lesion can be detected with white light imaging, but TXI makes it easier to recognize the lesion due to the difference in color tone. This is the last case. As before, lesion of lesser curvature become easier to be detected by TXI. Because TXI is new technology, usefulness of this modality in clinical practice needs to be evaluated in future. This is the last slide. Image-enhanced endoscopy is becoming an essential technique in the diagnosis of early gastric cancer, and it will continue to evolve. Therefore, we also need to continue to learn about its mechanism and usefulness. Thank you for your attention.
Okay, thank you, Yoshida Sensei. So maybe next topic is also the same for detection of early gastric cancer. So maybe we will hear the video presentation from Dr. Doi. Could you start? So in summary, NBI, maybe unfortunately for the detection rate, even you enroll 4,000 cases, but it could not show significant difference. So next, Dr. Doi Osamu's presentation, please. Video presentation.
Good evening, everyone. My name is Osamu Tohi from Kyoto Prefectural University of Medicine in Japan. Today, I'd like to talk about the diagnosis of early gastric cancer in IEE, LCI, BLI, and others. Today's contents are endoscopic diagnosis of Helicobacter pylori infection using BLI and LCI, and endoscopic diagnosis of early gastric cancer using BLI and LCI. I have reported the review of Kyoto classification of gastritis. The purpose of Kyoto classification is to identify H. pylori infection and the risk of gastric cancer. Some findings were identified the risk of intestinal type and diffuse type gastric cancer. Normal mucosa is a smooth, a little shiny, fresh color mucosa. Lack is a specific finding of H. pylori uninfected stomach on the gastric angle. Nodularity and diffuse redness are reliable findings of H. pylori current infection. Nodularity is goosebump-like mucosa on the antral. Diffuse redness is an obvious redness on the greater curvature of gastric body. Map-like redness is a specific finding of H. pylori post-infection, especially after eradication therapy. This is a reverse phenomenon opposite to diffuse redness, so that lesser curvature is reddish and greater curvature is whitish. Let me give a brief introduction to laser reel system using two different narrow laser sources. White illumination light is discharged from the phosphor existed by 450 nanometer laser, and blue laser imaging BLI is mainly made by 410 nanometer laser. This slide shows the relation between irradiation light and each mode. BLI bright and LCI are brighter modes than BLI with combination of 410 nanometer and 450 nanometer laser. BLI is suitable for magnifying observation because enhancing microbacilles and the microstructure of gastric mucosa. However, BLI is dark from the distant view. BLI bright compensates for the darkness of BLI. Magnifying endoscopy with BLI have reported to be useful for diagnosis of gastric intestinal metaplasia. Blue whitish light lines can be seen with magnifying BLI. Called the light blue crest, this is a specific finding for gastric intestinal metaplasia, and this finding has a strong association with presence of CD10 positive rush border reported by Professor WEO. LCI was developed as a novel IEE. The concept of LCI is to provide color enhancement of mucosal color by color transformation, to give similar color to WLI, but to be brighter image than WLI. LCI both expands and reduces mucosal color information so that the reddish color becomes redder and the whitish color becomes whiter. We found LCI enhanced diffuse redness and retrospectively investigated the diagnostic performance of LCI. Diagnostic performance of LCI is superior to that of WLI for H. pylori infection according to diffuse redness. LCI enhances a finding of intestinal metaplasia like a purple spot. Dr. Ono called it lavender color sign. The sensitivity and accuracy of LCI was significantly higher than those of WLI. We reported that LCI identified map-like redness, and emergence of map-like redness was a risk of gastric cancer detected after H. pylori eradication, in the cross-sectional study. Emergence of map-like redness is an independent risk factor of gastric cancer incidence after H. pylori eradication. LCI enhances other findings of Kyoto classification compared with WLI. LCI enhances atrophic border, which is a finding of current or past infection. This case is a current H. pylori infection. LCI enhances both the whitish atrophic mucosa and diffuse redness. By the way, do you know how WLI overlooked early gastric cancer? In Japan, overlooked rate was reported to be 14% to 75%. In other countries, overlooked rate was reported to be 4% to 22%. So WLI has a limitation for gastric cancer screening. Gastric cancer detection in WLI and BLI bright were evaluated back-to-back endoscopy in a prospective randomized controlled study. Sensitivity of primary WLI and BLI bright was 50% and 93.1% respectively. Therefore, BLI bright improves gastric cancer detection and reduces missed gastric cancer. LCI improves visibility in 73 to 76% of gastric cancers compared with WLI in a subjective evaluation. LCI has the greatest color differences than WLI and BLI bright using LAB color space analysis. LCI find trial was performed to compare the detection of upper GI neoplasms between WLI and LCI with back-to-back endoscopy similar to the former BLI bright study. This multi-center prospective randomized controlled study was conducted in 19 Japanese institutions. 1,500 patients were scheduled to be enrolled in this study. The participants were randomly allocated into WLI and LCI group. In WLI group, endoscopic examination using primary WLI were performed in pharynx, esophagus, and stomach. Following examination were performed using secondary LCI as same. Conversely, in LCI group, primary LCI observation were performed following secondary WLI observation. 1,508 patients were enrolled and allocated randomly. Finally, 752 patients in WLI group and 750 patients were analyzed in this study. The patient characteristics was not significant difference between the two groups. Overall detection rate of upper GI neoplasms were 8% in WLI group and 8.7% in LCI group. There is no significant difference between the two groups. Cancer detection of primary WLI and LCI was 4.8% and 8% respectively. Risk ratio was 1.67 and significant differences were found. Therefore, LCI detected more upper GI neoplasms than WLI. Furthermore, overlooked rate of primary WLI and LCI was 3.5% and 0.7% respectively. There was a significant difference between the two groups. Therefore, primary LCI reduced overlooked neoplasms compared with primary WLI. Most detected gastric neoplasms were intestinal type of adenocarcinomas in the both two groups. The high confidence rates were 54.1% in primary WLI and 86.4% in primary LCI.
Next case is a well-differentiated adenocarcinoma after H. pylori eradication therapy, detected by LCI and overlooked by WLI. Can you detect the lesion using WLI? You can easily detect the lesion using LCI. Because LCI enhances tumor color as an orange area and the surrounded map-like redness as a lavender color.
Next, magnifying endoscopy is useful for diagnosis of gastric cancer. Vessel plus surface classification system was established in Japan. Microvessel and microsurface pattern were independently classified as regular, irregular, or absent. Diagnostic criteria of gastric cancer were irregular microvascular pattern with a demarcation line or irregular microsurface pattern with a demarcation line. Now, magnifying endoscopy simple diagnostic algorithm for early gastric cancer methodology has been published. When we detect a suspicious lesion, identification of demarcation line is the first step, and irregular microvascular or microsurface pattern is the second step. The criteria of early gastric cancer are an irregular microvascular or microsurface pattern with a demarcation line. This case is a well-differentiated adenocarcinoma located on lesser curvature of middle gastric body. WLI shows unclear margin and can be diagnosed as a gastric cancer with low confidence. However, magnifying BLI shows irregular microvascular pattern with a clear demarcation line. A prospective comparative study was performed to evaluate diagnostic accuracy between WLI and magnifying BLI. We analyzed 127 detected lesions, including 32 early gastric cancers, according to VFS classification system, and evaluated diagnostic accuracy compared to WLI to magnifying BLI. The sensitivity, specificity, and accuracy of magnifying BLI 90%. Magnifying BLI significantly shows excellent diagnostic performances compared with WLI. LED endoscopic system has already been developed. We prospectively compared WLI and LCI between LED and laser systems. LED LCI did not have different visibility from laser LCI. Each LCI has superior visibility than each WLI.
Diagnostic accuracy of LED magnifying BLI and laser magnifying BLI was 93.7% and 94.9% respectively, according to VSCS. There was no significant difference between the two modalities. AI diagnosis using LCI is useful for diagnosis of H. pylori infection. The accuracy of AI with LCI was 87.6%. Sensitivity was 90.4%, and specificity was 85.7%. These results were excellent, similar to expert endoscopists.
This paper is to evaluate the accuracy of AI with WLI, BLI bright, and LCI. AUC of LCI was the highest. Therefore, LCI was also excellent for AI diagnosis. Summary: endoscopic screening is essential to evaluate the risk of early gastric cancer, according to Kyoto classification of gastritis. Equipment-based image-enhanced endoscopy, BLI and LCI, is useful for diagnosis and detection of early gastric cancer. LED BLI and LCI can be as easily available as laser BLI and LCI. I have two questions for you. Question 1. Can you diagnose H. pylori infection status in this case? Which is correct? Current infection, past infection, uninfection, or autoimmune gastritis? In this case, atrophy positive, intestinal metaplasia positive, diffuse redness positive, lack negative, macular redness negative. Therefore, this is a case of current infection. Next question. How do you diagnose presence or absence of the neoplastic lesion and the H. pylori status in this case? 1. No neoplastic lesion and H. pylori current infection. 2. No neoplastic lesion and H. pylori past infection. 3. Gastric cancer and H. pylori current infection. 4. Gastric cancer and H. pylori past infection. This case is a well-differentiated adenocarcinoma after H. pylori education. You can easily detect the lesion using LCI because in LCI, tumor looks an orange area and surrounding macular redness looks a lavender color. Thank you for your kind attention. I'm looking forward to seeing you at the end of 2022 in Kyoto.
Thank you, Yoshida Sensei and Doi Sensei. So both presented for detection of early gastric cancer. Yoshida Sensei used NBI, non-magnifying NBI, and Doi Sensei used LCI for detection. And also, Doi Sensei presented about the importance of diagnosis of atrophic gastritis. I think this is also important because we can pick up high-risk patients to put on a surveillance endoscopy. So anyway, it's negative or positive, still large study, sample size study, so prospective randomized control trial, so including enrolling more than 1,000 or 4,000 patients. So do you have any question for each other? Don't fight. But about the difference of, result or some, of course, method is different, but do you have any question each other before going to a case discussion?
Then I have one question. Dr. Doi, do you evaluate the detection rate of gastric cancer between two methods? Statistical evaluation.
LCI find study include all hypopharyngeal, esophageal, and gastric cancer for primary lesion to detect. So what is the statistically different for only specific for gastric lesion?
Yes, thank you for your question. So there is a statistical difference between the primary LCI and the primary WLI, but Dr. Uedo mentioned LCI find trial is
including pharynx, esophagus, and stomach. So in only stomach area, the detection rate of gastric cancer is not significant difference between primary LCI and primary white light imaging and primary LCI. So, but this is a limitation of the sample size, I think.
But basically, sample size was calculated, including all upper GI region,
Yes.
1,500 cases. Okay,
Yes.
and you could show the statistical difference. So, and I think LCI uses shortwave length light as well. It means compared to similar to NBI compared to TXI. I think LCI still include shortwave length light that is used for NBI. So I think it is also good for detection of squamous cell carcinoma because NBI is very useful for hypopharyngeal or esophageal cancer. So maybe not only TXI enhancement using white light, maybe LCI may be better for squamous cell epithelium, but I don't know, but just a speculation. So anyway, I think one question is from audience that Dr. Doi Sensei, could you differentiate incomplete or complete intestinal metaplasia by LCI or BLI? Type of intestinal metaplasia.
Yes, LCI enhance the intestinal metaplasia like lavender color sign, but LCI both enhances the lavender color sign, complete intestinal metaplasia and incomplete metaplasia. The same color.
So still difficult.
Yes. So diagnosis is very difficult.
Difficult. I see. I think many magnifying endoscopy is still difficult to distinguish. And what do you recommend for the patient with past H. pylori infection? You mentioned that LCI, some map-like redness is very important to make diagnosis of patient with past infection of H. pylori. So, do they still need surveillance or intensive surveillance on something because they already eradicated H. pylori?
Yes. So I think the patient with map-like redness is a high risk for gastric cancer. So I recommend past infection stomach with map-like redness or severe atrophy is also high risk of gastric cancer. So I think map-like redness or severe atrophy is recommended to the surveillance endoscopy for gastric cancer.
I see. I think there is an investigation that that show that map-like redness is histologically intestinal metaplasia.
Yeah.
So patient with extensive intestinal metaplasia in the corpus, gastric corpus, has still high risk for development subsequent cancer even after eradication therapy. I think that is an interpretation of the endoscopy finding of map-like redness. Okay,
right.
So Doi Sensei, do you prepare case discussion?
Yeah. Yes. So I will share you my slide.
Maybe Honchi also participate for the discussion.
Okay.
Can you see it?
Yes.
Okay, I will start my case discussion and quizzes. Case discussion. The patient is a 68-year-old man. There are no cancer history and no symptom. The patient underwent health checkup and endoscopy. So this is endoscopic images in the stomach and antegrade view. Right is LCI and left is WLI. This right is a retroflex view. Right is LCI and left is WLI. So question 1, what is H. pylori infection status? Please. 1, infection. 2, current infection. 3, past infection. 4, autoimmune gastritis. Please vote.
So diagnosis of background gastric mucosa by LCI and maybe white light as well. Okay, could you show the answer? So 8% infection and 42% current infection and 42 for past infection and 8% for autoimmune gastritis. So difference between current and the past infection is a bit difficult. Could you explain by endoscopy finding?
Okay. So the answer is past infection. The non-atrophic mucosa on the greater curvature side is whitish, and conversely, atrophic mucosa on the lesser curvature side is reddish. So this is a reverse phenomenon, and with map-like redness. So in this case, is a past infection.
Probably, if it is active or current infection, usually corpus greater curvature mucosa, non-atrophic mucosa is redder than atrophic mucosa. Atrophic mucosa is more pale compared to non-atrophic mucosa, but this is opposite in color, white and red. So that is a indicative sign for past infection. I see.
Thank you.
Okay.
Okay, next. So this is antegrade view of the lower gastric body. You can see the region on the posterior of lower gastric body. Right is LCI image, left is white light imaging. Next image is the same region using BLI. Right is antegrade view, left is antegrade view, and right is a retroflex view. These are non-magnifying image. So question 2, what is your diagnosis of the lesion? Please vote 1, non-cancer, 2, adenocarcinoma or high-grade dysplasia, 3, adenoma or low-grade dysplasia, 4, multiple lymphoma. Please vote.
Okay, so 3% non-cancer and 69%, 70% adenocarcinoma and 17% adenoma and 10% multilymphoma. So could you explain differentiation between adenocarcinoma and adenoma? And if you can, maybe you can explain finding of multilymphoma, please.
Yes. Okay. The answer is adenocarcinoma. So this region is a slightly depressed region with erosion. You can see well demarcated reddish area in WLI, but LCI more clear, the region margin. The margin of the region is irregular and not smooth margin, and partially spiked edge. So these characteristics predict cancerous lesion.
So what is the difference from adenoma?
So typical characteristics of adenoma is whitish or discolored, slightly elevated region, and this region is not typical findings of adenoma.
More reddish and depressed.
Yes.
Okay. And I also found that maybe lesion area is very orange, bright reddish color, and the surrounding mucosa looks a bit purplish, as you mentioned. So this is surrounded by intestinal metaplasia, is it?
Yes. So lesser curvature side of the region, intestinal metaplasia, and opposite side is non-atrophic mucosa. So this area is marginal zone between atrophic mucosa and non-atrophic mucosa. So marginal zone is often detected the early gastric cancer.
High risk area.
Yeah, high risk area. Yes.
I see. Then, do you have another question?
Yes. Next.
Okay, so please.
This is magnifying endoscopy with BLI. Left image is the center of the region, and right is center and to greater curvature side of the region. So question 3, how do you diagnose microsurface pattern and microvascular pattern? 1, regular MSP and MVP. 2, irregular MSP and regular MVP. 3, regular MSP and irregular MVP. 4, irregular MSP and MVP. Please vote.
Okay, so for answer 0%, 0 for regular microsurface and microvasculature, and 20% irregular microsurface and regular microvasculature, and 8% regular microsurface and irregular microvasculature, and 70% is both irregular microsurface and microvasculature. Okay, could you explain how we evaluate the vasculature and surface structure?
Yes, answer is irregular microvascular pattern and microsurface pattern. Maybe this is the easy question. Microvessels have tortuosity, caliber change, dilated and non-uniform shapes. There is a irregular microvascular pattern. And microstructure is mixture, irregular, and absent microsurface pattern. But majority is irregular microsurface pattern.
So this, okay. Honchi, could you explain well in English instead of us?
Okay. Well, I actually think this lesion probably has an ulcer or erosion in the center. So in the center, there's absence of anything. So this is an ulcerated or erosion region. And on the right photo, I think the important thing is first recognize the demarcation line.
Yes.
So first you can see that on the edge of the photos, both photos, you can see a clear-cut demarcation between abnormal and normal area. So this is a demarcated area according to the Mester G. And then you focus onto the microvascular and microsurface pattern. The vessels, this is a bit small photos, but anyway, the vessels are quite irregular in morphology. I think previous study has found that non-uniformity is the most important factor to predict the malignancy. So you look for the uniformity of each of these vessels. And one hint is that if you look into the vessels and the association with the microsurface pattern, you can see the vessels actually cross around all the microsurface pattern. So this is also one thing that gives you a hint that this is probably not a good sign or probably malignant. And so this is about interpretation of the microvascular pattern. For microsurface pattern, I think it's more difficult in this case. Some area you cannot see any surface pattern at all. So it could be a very flat, the absence of any surface or papillary structures is all completely flattened because of the neoplastic change. And maybe on the right photo in the right lower corner, there are some open surface pattern, no longer in a papillary pattern, but somehow areas with open loop and areas with closed formation. So these are more irregular. I think in the middle in the right picture on the center part, just next to the erosion, that is a regenerative mucosa. I don't know, maybe from previous ulceration. Do you agree that area may be regeneration?
Or some mucus, sticky mucus or something, but we don't know.
Yeah.
We cannot evaluate there. Yeah.
Yeah.
But for microstructure, uniformity of microstructure on the left image, sometimes, Kenshi Yao said that we put, cross and divide it into 4-quadrant structure. So maybe right upper and right lower and the left lower, each structure is a bit, heterogeneous. Yeah, different. Yeah. That is maybe we can call irregular microstructure, I guess. Okay. So, Doi-sensei, do you still have question, please?
Yes. Last question. This is a magnifying view near the edge of the lesion. So last question 4. Where is the demarcation line? 1 red line, 2 yellow line, blue line, for no demarcation line. Please vote.
Okay, so for answer, red line is 23%, 20% for red line, and most is 58% for yellow line, and 15% blue line, and 4% no demarcation line. So maybe most is yellow line, difference of color and structure, but still some doctor vote for red and blue line. So minority of audience voted. So could you explain, Toi-sensei?
Yes. So answer is yellow line. So red line is inside of red line is absent microsurface pattern, but outside of red line is irregular, but not absent microsurface pattern. So yellow line is inside of yellow line is irregular microvascular pattern, and outside of the yellow line is regular micro surface pattern and regular microvascular pattern. So yellow line is demarcation line. So ESD was performed for this region. Pathological diagnosis is adenocarcinoma type 1 and type 2, mainly well differentiated adenocarcinoma, type 02C with ulceration. Size is 18 millimeter. Depth is SM1, 400 micrometer invasion. No lymphobascular invasion. Emerging was negative. This is HE image is number 7 in the center of the lesion. The center of the lesion is erosion, and very small area with SME invasion. So I will show you the one-to-one correspondence magnifying image and HE image. The number 7 cut line is here, and cut line is here. Red arrow is corresponding to magnifying image and HE image. Yellow arrow is the same. So in HE image, so in the center of the lesion is cancerous tissue is on the surface, but at the edge of the lesion, the non-cancerous tissue is surrounded by covered with cancerous tissue. So red is cancer and blue is non-cancer. So at the edge of the lesion, partially covered with non-cancer tissue on the cancer area. So there is a two different lines, red and yellow, is different characteristics of the region.
Okay, thank
That's
you.
all.
Yeah, I think you mentioned that between red and yellow arrowhead, you mentioned that the cancer is covered with non-cancerous epithelium, but according to this scheme, maybe cancer is exposed on the surface, and the bottom there's an intestinal metaplasia. But anyway, within the red arrowhead, whole layer of the mucosa is replaced by cancerous glands. But in between red and the yellow arrow, still somewhat like a two-layer structure
Yeah.
from the intestinal metaplasia and the cancers. That such kind of structure is represented as a difference of magnifying BLI image, but a very clear explanation. And the central part is ulcer.
Yes.
Ponchi was right. Yes. Okay. Anyway, maybe because of the time, we can. Thank you, Doi Sensei.
Thank you.
Detailed correspondence between endoscopic and histological image. So next, please proceed to my video presentation. Thank you for staying with us. This is the last video presentation and case discussion. Okay. Thank you for allowing me to give a presentation in this course. A title of my presentation is Diagnosis of Superficial Upper GI Neoplasm by Magnifying Endoscopy, Zoom, Near Focus, and EDOF. In this lecture, you would learn the term high definition, high resolution, and high magnification. Difference between digital zoom and optical zoom, and difference between zoom endoscopy and near focus endoscopy. Magnifying endoscopy is usually used in combination with image enhanced endoscopy, but it is classified as an independent category of endoscopic imaging. It includes optical zoom endoscopy and digital zoom endoscopy. At first, let us understand a term high definition. High definition is usually used for quality of video images. High definition video images are larger than standard definition images. Therefore, it contains more pixels. The left side is a standard definition image which was taken in 2014 for submission of paper for diagnosis of gastric intestinal metaplasia. The image size was 640 times 480 pixels, while on the right side, full high definition images has 920 times 1080 pixels. So when we look at the image in the same size, resolution of a standard definition image is lower than that of a high definition image. So the image looks a bit blurry, and the letters in the standard definition image are jaggy on the edge. Then I would like to explain difference between digital zoom and optical zoom. Although both methods magnify the size of an image compared to the original one, but the digital zoom just enlarges the size. So resolution of the original image does not increase. However, in optical zoom, the images are optically magnified, so the resolution of the images become higher, enabling us to observe detailed structure of a small object. Historically, we observe color and surface morphology for endoscopic diagnosis. However, recent advancement of narrowband imaging technology added the concept of vessel diagnosis to these diagnostic algorithms. So, what is the smallest unit of vasculature? It is the capillary, which has 8 micron diameter. So, it is important to resolve this 8 micron structure to use vessel finding for accurate endoscopic diagnosis. If the quality of original image is not enough high, the digital zoom may not resolve this microvessel structure. However, optical zoom can resolve the microvessel architecture and make vessel diagnosis possible in addition to the conventional color and surface diagnosis. Then, I would explain about near-focus technology. In regular mode, a conventional near-focus scope can get the focus in an area between 100 mm and 7 mm distance. However, when we get close to the object, the endoscope cannot catch the focus in a near area. But when we push the button, the objective lens is moved and we can get the focus in a close area between 7 mm and 3 mm distance. And if we get close to the object, principally it looks larger than that is in the far distance. This is an endoscopic image of 10,000 Japanese yen. In regular mode of near-focus endoscopy, we can get the focus by this distance. But if the scope gets closer than this, we cannot get the focus. But in near-focus mode, we can perform close-up observation and see the object in a large image in detail. And for example, we can recognize letter Nippon Ginko on the bill. And if we use digital zoom, the image is enlarged further. Then, let us see the real endoscopic images. This is a shallow depressed early gastric cancer at the corpus lesser curvature. When we switch to NBI mode and press the near focus button, we can observe presence of demarcation line and irregular microvessel pattern of the lesion. However, when we use optical zoom scope, more detailed characteristic of the microvessel can be seen. In both near focus and optical zoom endoscopy, demarcation line is similarly observable. However, for evaluation of irregular microvessel pattern, optical zoom endoscopy provides better resolution of microvessel architecture than the near focus endoscopy, enabling us to make accurate diagnosis according to vessel findings. Nevertheless, how such difference in resolution of microvessel pattern impacts endoscopic diagnostic accuracy has not been known so far. But Dr. Yoshida conducted a multicenter randomized control trial on gastric cancer detection using near-focus NBI endoscopy. And in the secondary analysis of that study, diagnostic accuracy of near-focus NBI for characterization of early gastric cancer was investigated. According to the data, near-focus NBI showed accuracy of 88%, sensitivity of 61%, and specificity of 97% for differentiation between cancer and non-cancer. When the data is compared with the previous randomized control trial using optical zoom endoscopy, the diagnostic ability of near-focus NBI are better than white light diagnosis and almost the same to that of sole optical zoom endoscopy. However, the diagnostic ability of near-focus NBI was not as good as combination of white light endoscopy and magnifying NBI endoscopy. So, maybe this difference in diagnostic accuracies is derived from difference in resolution of microvessels between near-focus endoscopy and optical zoom endoscopy. Then, I would introduce the latest endoscopy system. This system consists of image processor equipped with new image enhancement mode, texture, and color enhancement imaging, as well as NBI. And the scope is equipped with the extended depth of field EDOF technology. As I explained, previous near-focus scope works between 100 mm and 7 mm area in a focus in regular mode, and it works between 7 mm and 3 mm area in near focus mode. However, the EASY 1500 covers between 100 mm far area and 3 mm close area. It doesn't work. Oh. Shall I explain with slides?
Let me
Sorry.
quickly pull up your slides, yes.
Okay. Oh, okay.
Bear with us, we are pulling up the slides.
How can I?
Professor Ueda, do you have your slides ready?
Yes. Or could you restart video?
I'll try.
Mm-hmm. Or maybe it's better to explain in a slide. Okay. So this is a old HQ scope. It works with regular mode, near focus mode like this. But the EASY 1500 cover the both 100 between 100 to 3 mm distance. And then if we use near focus mode in this EASY 1500, we can see more closer observation to the closest area between 5.5 millimeter and 1.5 millimeter. So this is enabled by the use of beam splitter to achieve near focus image and the far focus image was merged in the two image sensor and make it in a combined image of the very extended depth of focus, pan-focus image by this system. This technology is called EDOF, extended depth of field. So what we found in this scope is that even regular mode, we can get close to the object so that even regular mode, we can achieve almost the same magnified image to near focus mode in the old HQ scope. So even regular mode, we can see Nippon Ginko letter in this image. And then if we press the button, we can get more closer so that we can achieve about 1.5 larger, 1.5 times larger image in near focus mode. And with electrical zoom, we can achieve such kind of high magnified image. So I explained mainly about the close observation or magnified observation, close-up observation, but it also works for far focus area as well. So in the optical zoom, far area, it's out of focus, but this near focus plus EDOF extend the depth of focus field like this. So what impact for clinical practice is sometimes margin of such kind of polypoid lesion is blurry, but we can achieve very sharp focus in such lesion. And for this such kind of depressed lesion, only demarcation line and the irregular microvessel can be seen in the proximal part. However, EDOF provides microvessel pattern and the demarcation line in whole depressed area like this. So what enabled us to do magnifying observation is we can achieve very wide focused area, so image become stable. I explain with the image. So TXI mode showed the slightly elevated whitish lesion here. And then with NBI magnification optical zoom, we can see demarcation line and irregular vessel, but the image is a bit unstable. So we have to freeze the image to evaluate the microvessels and demarcation line. So, and also I really use delicate maneuver of the scope and the delicate adjustment of the magnifying lever. But the near focus plus EDOF, just switching the button, we can achieve such kind of panoramic view of good focus in stable image like this. So this is a still image of captured by optical zoom and near focus plus EDOF. So probably magnification level is a bit smaller, lower in near focus plus EDOF, but you have to note that even EDOF a bit lower magnification level, but EDOF really resolute every single vessel appearance in this image. So we can really evaluate 8 micron meter capillary finding in this image. So important thing is not the magnification level, how resolute the small structure. That is the most important for vessel diagnosis. So in summary, high definition image sensor and video processor improve resolution of video endoscopic images. And the latest zoom and near focus endoscope provides high magnification and high resolution image that resolve the smallest unit of the vessel to make accurate endoscopic diagnosis. And the EDOF lower the bar for magnifying observation of superficial upper GI neoplasm and may disseminate magnification endoscopy diagnosis in clinical practice and benefits medical care of cancer patients. Thank you for kind attention. Okay. So maybe because of the time, I will share my case presentation. Wait a moment. Sorry. Okay. Okay. So maybe I will ask panelists for their opinion. So each patient is a woman in her 50s and had H. pylori eradication therapy 2 years ago. And the surveillance endoscopy and biopsy reveal abnormal finding. Like this. This. This is AFI image, but just for reference. But you have to focus on white light image. This. This. So what is main diagnosis? Oh, sorry. One, H. pylori associated gastritis. 2, autoimmune gastritis. 3, non-Hodgkin lymphoma. 4, early gastric cancer. And 5, advanced gastric cancer. Please vote. This is advanced ADEC, advanced diagnostic endoscopies, and we focused on IEE, but I think still white light conventional observation is very important before we perform IEE. So could you show the answer? So for answer, 18% H. pylori associated gastritis because she had H. pylori infection already. That is correct, but 7% autoimmune and 18% non-Hodgkin lymphoma and 43% early gastric cancer and 14% advanced gastric cancer. Honchik, do you have some comments?
It's quite
for this diagnosis.
difficult case. Huh? I think initially in an not adequately insufflated stomach in the previous photos, the folds looked a bit thickened in the greater curvature, and there's definitely irregularly arranged redness around this region. So, but I didn't really see a clear-cut demarcated area. So I would, and then also there was one photo showing a slightly closer look, but on that glimpse, I did not see a very irregular mucosal pattern. It seems that there's something beneath rather than something on the surface, I would say. So one thing I might consider is lymphoma, and the other is infiltrative type of cancers, which is advanced cancers. So in this case, I would have the two diagnoses in my mind.
I see. Okay, so do you have any comment, Yoshida sensei or Doi sensei? very short.
Sorry.
What is the answer? Your answer.
My answer is no Hodgkin lymphoma.
Mm.
Differential diagnosis is early gastric cancer because usually early gastric cancer occur from atrophic gastritis area. So it is common in occur this area.
Okay. How about Doi Sensei?
Yes, I think this is a early gastric cancer case.
Okay.
At the reddish depressed region, very clear margin.
Answer is diverse. So let's use IEE. I think I hope video move well, but this is a depressed area, so you can see irregular vessel. Maybe it helped to differentiate lymphoma and adenocarcinoma, I guess. But anyway, like this. So this is a margin of the depression and the edge of depression and center or periphery of depression. So what is answer? Predictive histology, intestinal metaplasia, differentiated type early gastric cancer, undifferentiated type early gastric cancer, or multiple lymphoma. Please vote. Okay. How about the answer? Okay, for answer, 4% intestinal metaplasia, 50% diffuse differentiated type intestinal type early gastric cancer, and 36% undifferentiated type diffuse early gastric cancer, and 11% multiple lymphoma. So bit difficult to distinguish between differentiated type or undifferentiated type. So, Honchik, could you give some comment?
Okay. I think this lesion is on macroscopic view is slightly depressed. So a depressed lesion, it's diverse. So an elevated lesion almost always is differentiated. Depressed lesion can be differentiated or undifferentiated. There is almost absent in any microsurface pattern in the center of the lesion. That's also one thing that might point to a undifferentiated type. I think, I'm not sure, but some areas there might be some corkscrew pattern of vessels. I'm not 100% sure, but I would suggest this probably is undifferentiated type. And also the location is in the greater curvature. So not exactly the typical location for a differentiated type cancer.
Okay, so short opinion from Yoshida Sensei. What is your answer? No reason, just answer. Dr. Yoshida?
Sorry, my answer is differentiated type EGC.
Differentiated type. Okay. How about Doi Sensei?
My answer is undifferentiated type EGC.
I see. Diverse. Okay, so I will show the answer. So actually, I took biopsy from the central depression and 1, 2, and then from the surrounding mucosa, like this. And the initial 2 biopsy from the depression showed signet ring cell carcinoma. And the surrounding mucosal biopsy show inflammatory mucosa. But actually, I suspected like Honchi because of some slightly thickened fold, and the distribution is not symmetric. Anterior wall side is very smooth, but the posterior wall side or right side of the greater curvature is only thickened and a bit limited in this area. So I also suspect some diffuse infiltrative cancer. So we send the patients to surgery. This is she received total gastrectomy. So this is the area, and this is a small depression. And we cut section like this, and there is a clip to identify the depression. So this is here. So I don't know, maybe young surgeon cut the central part of the lesion, but we can identify on the surface, there's a cancer cell, but otherwise, all mucosa was non-atrophic fundic gland. And then cancer is spread beneath the mucosa, underneath the muscularis mucosae. So in this depressed part, cancer invade some mucosa and through muscularis propria and reached to the serosa like this. So final diagnosis as a type 4 infiltrative cancer, 10 times 12 centimeter, and a poorly differentiated type with fibrosis, sclerous type. And the depth was T4 serosa, and the lymphatic and vessel permeation. But unfortunately, a patient did not have lymph node metastasis at this moment. Maybe in the future, she will have a really spread diffuse infiltrative advanced cancer. So, answer is advanced gastric cancer and undifferentiated type early gastric cancer. And I think there is two characteristic finding of undifferentiated type, diffuse type gastric cancer in magnifying NBI image. One is a vessel and the surface structure. So vessel, usually Honchi said that the corkscrew pattern is a characteristic finding. So it has sensitivity of 86% and a specificity of 96% for diagnosis of undifferentiated type early gastric cancer. And another is a surface structure. So that is also Honchi mentioned that usually so differentiated type, it has a gland structure. So surface is like this type of bumpy structure. So it can cause presence of surface structure like this. However, the diffuse type early gastric cancer, usually cancerous cell is accumulated in the lamina propria, and the surface epithelium become flat, or some gland become very shallow, orifice become very shallow. It disappear, make the surface structure disappeared. So absent microsurface structure pattern is a characteristic finding of undifferentiated type early gastric cancer with sensitivity of 93% and specificity of 80%. So as I mentioned, thickened fold with asymmetrical distribution was a clue to suspect infiltrative gastric cancer. And the lesion was only exposed at the shallow depressed area. And then, it invade some mucosa throughout the gastric wall. And this also suggests importance of careful observation with enough air insufflation, because initially we could not find such kind of depression. After extension of the gastric lumen, we can identify this type of lesion. Magnifying BI facilitate prediction of histological finding and target biopsy from this depression. Only here we could achieve good, accurate biopsy finding. And also, so maybe I want to emphasize importance of adequate observation method, enough extension of gastric lumen, and also it is also important to suspect some lesion with white-like macroscopic appearance. Sometimes we misunderstand that the use of magnifying observation or image-enhanced endoscopy can solve all problems for diagnosis, but still basic technique and careful observation with white light image is really important. And then on top of that, IEE or magnification adds some advantage to characterize the lesion. Okay, thank you for kind attention. Is there any comment or opinion?
So may I ask, so if you suspect it's a lymphoma, what would you see in image-enhanced endoscopy?
So I think Dr. Nonaka reported that there is a tree-like appearance, tree branch-like appearance. So not like a corkscrew, not tortuous, more little bit less tortuous. And then a tiny irregular vessel is branching from the thick vessel, such like kind of tree branch-like appearance. But that is all irregular corkscrew minute vessel with disappeared microstructure. So I think this is a undifferentiated type cancer. Yes. Okay. I think we are almost coming to the final stage. So anyway, thank you very much for everyone to stay with us. Still, we have almost the same number of audience from the beginning. So I hope you are not so sleepy during the presentation, during this session. So I would like to ask Professor Ray for the closing remarks. Professor Ray, please.
Thank you, Professor Wedo. Really, this morning for me, this afternoon in Japan, you make a marvelous team with a lot of picture. We understand from white light what is the basis. Image and endoscopy is still in progress and improve quite a lot. The last technology from Olympus, from Fuji, will help us to make a more accurate diagnosis. But definitely, as you see the discussion and the difficulty with diagnosis from even a top expert, definitely we hope in the future the development of AI will help us, not only the expert, but mainly for the routine endoscopists to use better image and endoscopy. And the future of endoscopy is bright. The endoscopy is already on hand. Image intelligence artificial is just a computer help, because if you don't conduct your scope properly, you don't use the technology, you will have a poor result. But I think we are on the way to improve again our diagnosis ability. So thank you for all. Thank you for all the technical team. And thank you for my good friend, Isao Tajiri. It's again a very successful ADEC courses.
Thank you. It's 5 minutes early, but better than late. I see. Have a